All right. Good morning, everyone. My name is Rochelle Lonn. I would not be the person I am today if I had not come from a broken home. Through the adversity I experienced as a child, I developed my love for education. At an early age, I found structure, optimism, and self-worth through education. As Nelson Mandela stated, education is the most powerful weapon which you can use to change the world. I changed my world with education. Given my desire for learning and a strong calling to serve others, nursing was naturally the career choice for me. Over the last 16 years, my employer, or my family, I should say, Sutter Health Memorial Medical Center, provided me with opportunities to grow from an entry-level nurse extern to my current position as a nursing director serving the oncology and women's health service lines. It was the promotion to this director role that accelerated me to pursue my DNP. My DNP project stemmed from my desire to establish fundamental programs within the comprehensive community cancer program that I oversee. A smoking cessation program seems simple, and with the right research, I was not that far off. On a personal note, I am a proud cat mother of 5 and love adventuring on motorcycle trips with my husband. Now let's get to what you're all here for. Let's talk about my project. My project was the implementation of a nurse practitioner-led smoking cessation program with use of the ASCO 5As. What is the background on this topic? Oncology care clinicians, or OCCs, as you'll hear me refer them to, manage patients through the cancer care continuum from initial diagnosis through survivorship. The management of modifiable risk factors related to the development or recurrence of cancer is an important practice of the OCC. Cigarette smoking is the most most prevalent modifiable risk factor for patients diagnosed with cancer, period. And 30% of all cancer deaths are attributed to cigarette smoking, per the American Cancer Society. Regardless of this, and surprisingly, the oncology specialty does not include structured training of the adverse health effects of tobacco and methods to mitigate those risks. There still remain no specific competencies in the medical oncology curriculum that are required for smoking cessation, even with smoking causing approximately 1/3 of cancers. So what does the data show? Tobacco use is the leading preventable cause of disease, disability, and death in the United States. Tobacco use is often established during the teen years. And as of 2020, the World Health Organization reported that approximately 23% of us in the US use tobacco. Let's expand on the OCC's practices and perspectives in regard to tobacco screening and counseling. Recent studies of OCC's tobacco cessation management practices revealed that 75% of them, a large majority, assess for tobacco use during initial intake visits. Most of them advise their patients, about 60% of them advise patients to quit. However, only 30% of these providers reported that they've received adequate training on smoking cessation interventions. The American Society of Clinical Oncology, their Quality Oncology Practice Initiative, completed a study of OCCs in the outpatient setting, which confirmed this, that 97% of the time they document smoking status, and only 47% provide tobacco cessation support. Studies show that even brief interventions by physicians are effective, showing long-term cessation rates of up to 20% with counseling and up to 30% when counseling is combined with other measures such as nicotine supplementation or pharmacotherapies. A deeper delve into the oncology provider perspectives revealed that tobacco cessation was a low priority at the time of cancer diagnosis, and instead they addressed the acute complications. This caused providers to assume a passive role tobacco cessation. They reported barriers such as lack of training, which we confirmed, limited resources for tobacco cessation, and ultimately they had a pessimism toward their ability to help patients quit, probably related to their lack of training. They also had a concern that patients would be resistant to quit. Evidence-based guidelines must be implemented, as the oncology specialty does not include structured training in the adverse health effects of tobacco or methods to mitigate those risks. So what's available? The American Society of Clinical Oncology developed some years ago the 5 A's of tobacco cessation, which are derived from the National Comprehensive Cancer Network guidelines. They include smoking status assessment strategies, individualized algorithms based on reported tobacco use, alternative approaches, behavioral therapies, and provide pharmacotherapy options. The content gears providers to practice the 5 A's of tobacco cessation, which are to ask, advise, assess, assist, and arrange. These guidelines are further supported by the Agency for Healthcare Research and Quality and the U.S. Department of Health and Human Services. The National Cancer Institute has also promoted these guidelines. These guidelines really guide the OCC to on how to facilitate authentic conversations with your patients regarding tobacco use and cessation. There's education that's available, and really just the clinical management of nicotine dependence. The main steps that do not get addressed primarily are the assist and arrange, the last 2 A's. These A's, once they're done and you do go through the 5 A's, there are 5 R's that you use as a motivational tool that providers can use to address excuses and help the patient determine their reasons to quit. The 5 R's are relevance, risk, rewards, roadblocks, and repetition. Further support has been garnered for smoking cessation post the pandemic in the cancer world because of the lack of prevention and screening and contact and other challenges that we had as a result of the pandemic. So what we see now is the American College of Surgeons Commission on Cancer actually just started a quality improvement initiative for their accredited centers this last year, making them accountable to report their assessment status of smoking use and tobacco use with patients. The American Cancer Society also got on board, and they recognize the importance of decreasing tobacco use through their Great American Smokeout campaign, which we're in the midst of right now. This is a nationwide campaign. If you haven't seen it, please look it up. If you know someone that smokes, make sure they connect to it. It's a great campaign, and I encourage you to get connected. Ultimately, the premise of the background that I want to share with you is the importance of nurse practitioners, which are shown to strengthen quality improvement efforts through their essential skills and practices of patient care, planning, delivery of care, and evaluation. The last thing I want to go on with the data has to do with the cost impact on healthcare in regard to tobacco's use. So it's not limited to the physical, as this addiction also has substantial economic impact on our healthcare system. Current smoker and former smoker survival rates are captured by life years, quality of life years, and averted premature death rates. Cost savings impact on healthcare systems for each of these categories is $9,100 per life year, $5,300 per quality of life years, and savings per lifetime quit of $11,000 per $400, and per premature death avoided, almost $60,000. So these combined results in a study that I found ultimately resulted in a 3% decrease in overall health costs per averted premature death. These combined calculate the lifetime care savings cost per quitter of approximately $11 billion. So it makes a difference. The research is there. So what was my PICO question, given all of this? Will the implementation of the American Society of Clinical Oncology tobacco cessation provider practices within a nurse practitioner-led smoking cessation program decrease tobacco use amongst newly diagnosed cancer patients? What did I do? First thing I did was I got to the numbers. I developed a business pro forma to obtain an NP for this program. What is a business pro forma? It is an exercise of calculating future financial risks or program operations based on projections and assumptions, volume, cases, and revenues. What we looked at was the projected relative value units, outcomes based on the expenses and revenues. Assumptions were made based on visits, which for this NP, we're going to also include delivering breast biopsy results, chemotherapy education, and oral chemotherapy, and also obviously tobacco cessation. The outcome yielded positive net revenue despite operational costs for the NP salary and benefits. Alongside revenue, access to care would also be improved, or was predicted to improve, with the addition of this NP. I will note that in our medical oncology practice, where this NP was originally hired into, this was the first nurse practitioner in this medical oncology practice of 4 medical oncologists. So we really had to overcome some cultural barriers, as well as really define the fiscal impact and the business side of this new person who would be doing these focused programs. Ultimately, our business plan showed sustainability, and that's a key component for program development. This is an exercise that can seem intimidating to healthcare leaders if they do not do their research and just work through the numbers. We got organizational buy-in through our cancer committee and our oncology medical staff committees. It was selected as a project that the oncology practice was going to delve into. So we got it through our accreditation, as well as we had it included as part of our quality improvement. The smoking cessation team, oncology nurse navigators, oncology financial navigator, licensed clinical social worker, lung cancer program medical director, and obviously our very important nurse practitioner. Got the team together, explained the project. I had the great help of this program to help me develop a protocol. We set up meetings, expectations, and roles, and agreed for the project protocol. Ultimately, what that entailed was the nurse navigators were the first to interact with these patients. They conducted a new patient orientation visit, where they completed a full scope social determinants of health intake visit while preparing that patient for their new cancer therapies. In this visit, current or former smokers were offered a visit with the nurse practitioner. If the patient declined, they were provided with tobacco cessation education. When the NP was referred the patient and saw the patient, she practiced the ASCO 5As, which included the development of an individualized quit plan for patients, which included timeframes, milestones to quit, pharmacotherapies or nicotine supplements if needed, referral to a social worker or other resource to support tobacco cessation. Patients who reported that they were not ready to quit were followed up by the oncology nurse navigator in approximately 4 to 6 weeks' time, and referred back to the NP as needed to address the tobacco use, along with coping status and treatments. 2 months into the project, our lung cancer program medical director, who was very hungry for a smoking cessation program, given that he's also a pulmonologist, asked if we could also add some of his pulmonary patients to come and also be an additional measure of preventing disease before development of cancer, and also progression of their own pulmonary conditions. So we did add those patients to the pool as well. What were my outcomes? What did we achieve? The intervention was offered to 49 patients who reported tobacco use. Initial patient responses were that the new cancer diagnosis caused increased anxiety and stress, resulting in the individuals not being ready to quit using tobacco. It was their coping mechanism. So that's something I'll talk about in a minute as an opportunity. Patients ultimately reported using tobacco, like I said, as a coping mechanism for stress, trauma, and changes in their life. Understanding the risks of continued tobacco use, most patients, about 23 of them, were not prepared to face the challenge of a new cancer diagnosis without their trusted coping mechanism of tobacco. Statements that patients included were, "What's the worst thing that can happen? Get cancer?" Or, "I don't even want to think of how I will get through chemo if I can't have a cigarette." Of the 25 patients who agreed to an appointment, 12 of the patients actually showed up and completed that visit with the nurse practitioner. 11 patients canceled or did not show up for the appointment. These patients were placed on a list to follow up with later. 7 of the patients that came for an appointment actually reported that they were ready to quit. Following the ASCO 5As and really reinforcing the assist and arrange pieces, the NP offered education support via the social worker referral or counseling, medications, and nicotine supplement. Ultimately, 3 patients were able to quit. Yes, 3. It's exciting. After receiving this tobacco cessation visit with the NP. Of these, only 2 had reported a readiness to quit, and interventions varied per patient, but they included education, medications, and nicotine supplements. Ultimately, what did this nurse practitioner program, or what did this NP-led program create? It created a pathway for us to address the leading cause of preventable death. Our cancer program now has a smoking cessation program, which was not present prior to this project. This, like I mentioned earlier, this NP was also the first APC hired into the medical oncology practice. Because of the focus on program development, she was successful in defining her care pathway for these providers, and we've actually just gotten approved for another nurse practitioner to continue with these efforts. My reflection, as you see on my poster, really is advanced practice nurses harness the ability to transform healthcare delivery systems. They're hardwired for quality improvement. To continue mitigating strains on the healthcare system, organizations must consider implementing NP primary care clinics. That's the next facet I'd like this to go, focused on disease prevention and screening. Healthcare leaders must maintain knowledge of evidence-based practices and develop their business acumen to meet the challenging demands of healthcare. And again, just lastly, mastering the business side of healthcare is essential for all nurse leaders. Lessons learned throughout my doctoral journey, and on a personal note, my doctoral journey has provided me with the practical skills to improve healthcare systems, resulting in improved patient outcomes. Through the DNP curriculum, I've been equipped with skills to translate and implement evidence-based practice. It is a privilege to join the scholars that paved the way for this degree. Previously, I was driven through my passion for leadership and service to others. Now I am armed with my DNP, or will be. I will be able to achieve my mission with this of continuing to make the changes that we want to see in our world, one practice, one provider, one program, and one patient at a time. I'd like to take a moment to thank you all. One never travels the road to achieve their goals alone. There are people along the way to provide you with knowledge, reassurance, and empowerment. I would like to thank my husband, Jason, and my family who wholeheartedly supported this doctoral journey. My chair, Dr. Mary Wyckoff, provided me with an unforgettable experience. She never questioned my ability, kept me focused, and fueled me with confidence. Thank you so much, Dr. Wyckoff. I could not have done this without my work family. Yes, my work family who's on the call. They cheered me on, believed in me, and helped me carve a path for this project. Lastly, I really just want to thank you, the faculty and staff at Samuel Merritt University, for making this program possible. Thank you for tuning in today for my presentation, and thank you for all your support.
Thank you, Rochelle. Wonderful job. Thank you.
Thank you so much, Rochelle, and thank you for your kind words. You can see that it takes a village for everyone to complete their projects. And as Rochelle was presenting, it's music to my ears whenever we are able to help nurse leaders to see how much our practices can grow with nurse practitioners. I am so proud of you and the ideas that you came up with and the support from your Sutter family and your personal family. This was an excellent presentation, and I think that all of us know the detriment of smoking, but although we know it, it is so hard to bring prevention to the forefront. But Rochelle, there was some things that in our practice sessions and in our talking that you shared with me that I would like to ask you about right now. What was something that occurred during your project that you did not anticipate, specifically regarding the culture surrounding?
I think one of the things that I wasn't certain would occur was the approval of bringing a nurse practitioner in. And although the business plan proved it on, with numbers, and it looked like it would be good, it was still the previous medical oncology providers who were feeling like they were losing touch points with their patients. They were losing control of their patients. And instead of fighting them on that, I just took time to listen, understand. And as we delved into the details of how this person would work, I figured one other huge piece of it would be, first and foremost, whoever we hire into this position needs to also understand the dynamics of our culture and where they're coming from. The nurse practitioner, Raisha Patterson, I don't know if she's on the line. I didn't see her name pop up. She was one of my mentors who actually was one of the first nurses who trained me on the oncology unit as a new nurse. And she's considered one of my favorite mentors of my career. She ultimately had just paved the way of nurse practitioners in a primary care clinic and was interested in coming back. And so it was ultimately through relationships, talking about opportunities, really listening, respecting everyone who's at the table. That is what made this possible. And it did not, had I directed it in any other fashion, saying this must be done because smoking needs to be addressed and outcomes need to be achieved, and we have to get this done for an accreditation, check a box. The doctors hate that. They want it to bring meaning. And so ultimately this nurse practitioner was hired based on her ability to relate, to connect with the providers, and ultimately proved herself through her connections with the patients. And so getting that business plan approval, I think that was a little bit of my aha in this project, because many times we get stuck in the weeds and we forget about, we get frightened when we have to go sit in front of the CFO, and we shouldn't be afraid. But in the background, it's not the numbers that are going to speak to our providers per se. It's more about the relationships that we have with them.
Thank you. And thank you for that detailed reply. That was really awesome. And it is very challenging to convince people to spend money. And you did a great job on not only that, but bringing the appropriate care to the patients that is really needed. So thank you for an excellent presentation. I would like to open Rochelle's presentation to our attendees for comments and questions, please.
I think Stephen has his hand up.
Thank you, Dr. Rush.
I do, but I'm waiting because I want other people to ask questions. It's probably more of just a comment, and actually you kind of left off with the thing that I wanted to pick up on, Rochelle, and that is talking about a business plan. And I think, speak for myself, I've been teaching nursing for a long time, and I've been a nurse a much longer time than that. And we really don't receive any education in our undergraduate or in our graduate programs about kind of the financial and business side of nursing, right? And there is a huge financial and business side. And I always think those nurses who go on and get their MBAs have really got one up on us sometimes when they're dealing with these types of things. So thank you so much for realizing that is a critical part of this project and probably almost every project that's been presented today. So I just wanted to say thank you for doing that, and keep raising that awareness among your colleagues that we've got to make, money talks. And as Dr. Wyckoff just said, people don't want to spend money, and they have really healthcare these days. And it's easy to say, oh, we can't afford that. But the fact that you were able to show what this costs over the lifetime is a pretty strong argument. So congratulations, kudos on that.
Thank you, Dr. Rush.
How about anyone else with questions or comments?
Dr. Wyckoff, I have a question.
Thank you. Go ahead. Dr.
Thank you. Rochelle, first off, excellent job. And I guess I want to, if you talked a little bit about it, but I'd like you to touch on, if you could, just a bit more, managing the change with having a new provider coming in as into the medical group, and how you were able to do that, because I think that is so difficult. And if you could just expand on that just a little bit more.
Yeah, so my strategy was, it's all in the family. For this specific scenario, Raisha grew up on the oncology unit upstairs and had worked with many of the physicians that were in the practice. So she was already credible She was already very respectful, and I think as she eased into the practice, she was not there to break any, to throw any waves at anyone for the first few months. It was really her seeing what the current practices were and how she could offer support where there might be any gaps. The initial conversations that I had, and ultimately I was with the physicians and their concerns about this, were really fueled by the fact that we, over the past, I can't even, it's probably over 10 years, probably 15 years, have been desiring a smoking cessation program, and we have not been able to implement it. So what is the problem? We need a plan. We need to start doing something. We can't just keep waiting for it to come around. It can't be managed by a doctor. We already tried that. There's too much busyness in their visits. And so ultimately, the drive was really, we had the perfect candidate. But had we had someone else, it would have been the same strategy, building those relationships, establishing a shared governance, and ultimately allowing for the team to come up with the plan and be included in that plan for execution.
Thank you, Rochelle. That's
That's
an excellent
wonderful.
plan.
Yeah, it's great. Thank you for sharing that. I really appreciate that.
I have another hand up. I believe it says your name is Kimberly Lewis.
Yes, I just have a comment for Rochelle. I have not worked with her very long, but she is incredibly dynamic and persuasive. And what appreciate most is the collaboration between social workers and advanced practice nurses, because two incredible groups of people that are vested wholeheartedly, and also to note the connection, the relationship, and the empathy that was required to really make this go forward, because you have to understand, you have to feel what people feel to have the passion that you see within Rochelle. So thank you for inviting me to see this presentation. Excellent. And I'm looking forward to many more years working with Sutter and also Rochelle. Thanks so much.
Thank you, Kim.
Thank you so much for everyone that was part of your team to join. And we are so grateful to you for helping us to do amazing projects within the community. I see another hand up, and I'm sorry, I don't know your name.
Oh,
so
that's
please-
my chief nurse.
Hold on. I'm home with COVID, so excuse I went off camera because I was coughing so much. But Rochelle, this doesn't surprise me at all. This is the level of work she does on everything. She has great passion for healthcare, and I particularly love this program. I said it in my chat, I had to go through lung cancer with both my parents who were heavy smokers. So hopefully this can get out and less people can suffer and lose their loved ones. So great job, Rochelle. I'm so proud of you.
Thank you, Ms. Barb.